All right, well, good morning for those of you on the West Coast and good afternoon for everybody else. It's our Best of SWOG, February 1st, 2023 edition, and we're going to start very momentarily. I do want to remind you, each presenter will have about 12 minutes to be divided by the speaker amongst their discussion, plus or minus any questions. If you do have any questions for them, please put them in the chat, and I will do my best to make sure that they are seen by the presenter. And finally, please remember that attendees can claim 1 hour of CME credit. You will get both a link and a survey later today in your email. So please check your spam if that doesn't happen. Without further ado, we're going to move right to Sapna Patel, who's going to be presenting in a recorded fashion on S1801. I'm sorry for the last minute change, but Dr. Patel is a very good citizen and was called in for jury duty. So if our team can go ahead and post her pre-recorded presentation, that would be great.
Thank you to SWOG and Dr. Blanke for selecting our presentation for the Best of SWOG webinar. This is the results of SWOG S1801 that were presented at the 2022 ESMO Congress in Paris. Neoadjuvant versus adjuvant pembrolizumab for resectable stage 3 to 4 melanoma. These are my disclosures. There's a fundamental question for resectable solid tumors, and that is, does treatment with immune checkpoint blockade before surgery induce an enhanced anti-tumor response, or is it simply delaying curative surgery? The rationale for adjuvant and neoadjuvant anti-PD-1 therapy goes like this. In the top row, if you remove a tumor, essentially you're throwing it away in a bucket along with all of the resident anti-tumor T cells. On the other hand, in the bottom row, if you administer drug therapy, such as PD-1 blockade, to a tumor before it is removed, you have the potential to enhance a larger population of anti-tumor T cells while that tumor is still intact. When you then go and remove the tumor and throw it away in a bucket, those anti-tumor T cells have already circulated systemically to sites of distant metastatic disease. So to test this hypothesis, that a neoadjuvant regimen of anti-PD-1 therapy would improve outcomes compared to adjuvant therapy of the same treatment, we designed the SWOG S1801 phase 2 randomized trial. Participants with resectable stage 3B to stage 4 AJCC 8th edition clinically accessible melanoma were randomized 1-to-1 to either treatment on the adjuvant arm, which was surgery, followed by 18 cycles of fixed-dose pembrolizumab, for treatment on the neoadjuvant arm, which was 3 cycles of pembrolizumab followed by surgery and 15 doses of pembrolizumab in the adjuvant setting. Surgery type and extent was pre-specified prior to randomization and was required to be carried out regardless of response to neoadjuvant therapy in the neoadjuvant arm. In this way, the same surgery was performed on both arms, and S1801 is not a referendum on de-escalation of surgery. If you look at the timing of radiographic scans in vertical green arrows, you'll note that they do not align on this study due to the different periods of treatment in both arms. Event-free survival was our primary endpoint, which was measured from the date of randomization to the first of the following events: progression or toxicity, where a study participant could not receive the planned surgery; failure to begin adjuvant pembrolizumab within 84 days of surgery, a standard window in melanoma; melanoma recurrence after surgery; or death from any cause. And to account for differences in time to adjuvant therapy, and owing to the difference in that timing of scan assessments that I just mentioned, participants on either arm who did not register to adjuvant therapy were assigned a landmark event-free survival of 84 days. And this was performed to avoid biasing in favor of the neoadjuvant arm, where the first study scan actually occurred at a later time than in the adjuvant arm. And the development of neoadjuvant toxicity could actually further delay the timing of a radiographic scan and the detection of an event. We enrolled 345 participants, 313 were eligible and randomized, and at a median follow-up of 14.7 months, we reached 104 events, which was our trigger for primary analysis. Event-free survival was longer in the neoadjuvant arm than the adjuvant arm, with a hazard ratio of 0.58 and a two-sided p-value of 0.004. Landmark 2-year event-free survival was 72% in the neoadjuvant arm and 49% in the adjuvant arm. Overall survival is immature. At the median follow-up period for this data, only 36 events had been reported. So this data is not mature and did not reach statistical significance at this time. Radiographic response in the neoadjuvant arm was assessed prior to surgery. There were 9 patients who achieved a complete radiographic response and 59 participants with a partial response. Crosshatches indicate participants with clinical disease progression who did not have a follow-up scan. And there were 42 participants who had an increase in target lesions of any percentage. 30 of these were still able to receive surgery. You'll hear at an upcoming Society of Surgical Oncology plenary session the outcomes of these participants. The majority of participants with increase in target lesions experienced progression at distant metastatic sites. One study participant who achieved a complete response and refused surgery remains disease-free without a recurrence at 31.5 months of follow-up. This is a graphical representation of the different periods of time on study, with surgery denoted by the bright blue boxes, pembrolizumab in light blue, and follow-up in gray. We drop the events in red bars on each study arm. There were 21 participants in the adjuvant arm who had an event during the surgical period. You'll see the one participant who essentially had an event prior to surgery, and the 20 that had an event after surgery prior to initiating adjuvant therapy. A similar number of participants experienced disease progression, 14 after neoadjuvant therapy prior to surgery and 14 after surgery prior to initiation of adjuvant therapy. The description of these early events is really important in S1801, as all adjuvant trials would have missed these events. For adjuvant trials, the time starts when you begin adjuvant therapy. And so participants who progress prior to surgery or postoperatively prior to the initiation of adjuvant therapy are not even eligible to be counted in those trials. So it's really important that we counted these early events so we can actually see what proportion of melanoma participants progress early in an early fashion. But then what you see on S1801 is that the majority of the remainder of the events that occur outside the surgery period are occurring during the adjuvant period in the adjuvant arm. Treatment-related adverse events were few, and rates of grade 3 adverse events were similar in both study arms. In the neoadjuvant period, less than 2% of all participants randomized to that arm experienced a grade 3-4 adverse event, the most common being increase in ALT. In the surgery and adjuvant periods, there was no statistical difference in adverse event rate, and neoadjuvant pembrolizumab, importantly, did not increase adverse events in the perioperative period. In summary, EFS, event-free survival, was significantly longer in the neoadjuvant arm than in the adjuvant arm, and landmark at 2 years was also significant. 8% of participants in the neoadjuvant arm experienced disease progression that precluded surgery, and 6.5% experienced residual disease or developed metastasis prior to the start of adjuvant therapy. A similar 11% of participants in the adjuvant arm experienced that same residual disease or developed metastasis prior to the start of adjuvant therapy. Again, those early events that we describe on S1801 that were not historically captured in other adjuvant trials. Tumor-related events, so that of disease progression or recurrence, have occurred in 20% of participants in the neoadjuvant arm and double that, 40% in the adjuvant arm. Overall survival is immature and no new safety signals were identified. So compared to the same treatment given entirely in the adjuvant setting, neoadjuvant pembrolizumab followed by adjuvant pembrolizumab improves event-free survival in resectable melanoma. We'd like to thank Our study participants, their caregivers, the late Val Guild and her daughter Sam, representing the voice of the patient in study design and execution, SWOG and NCI operations and staff, and the multidisciplinary study teams. Importantly, we'd like to thank the many study participants in the 90 different sites that enrolled in 35 states in the District of Columbia in S1801, nearly half of which were NCORPs, or National Community Oncology Research Practices, which tells us that we designed a study that was comfortable for the NCORPs, where in the community practices where the majority of these patients exist. Another important feature of S1801 is that the same surgery and same number of doses of pembrolizumab were given. And in this way, it makes it a cost-neutral regimen, not only important for practices across the U.S., but around the globe. Thank you very much.
So with apologies, Dr. Patel obviously can't, I assume can't answer questions unless she mysteriously appeared. Nope, that was still the video. In any case, I'm going to ask the admin team to capture your questions along with your name. We'll send them on to her and hopefully she can email you a response to the questions. I wish she were here so I could congratulate her live, because that was just a stellar presentation with profound implications for our patients, I hope. We're going to move on now to our second presentation. Dr. Parminder Singh will be talking about toxicity assessment from the SN1806 trial, which was presented at ASTRO 2022. Thank you for coming, Dr. Singh.
Thank you, Dr. Blanke, for giving us an opportunity to present our trial data at the Best of SWOG symposium today. So I'm presenting a phase 3 randomized trial of concurrent chemoradiation with and without atezolizumab in localized muscle-invasive bladder cancer. This is a toxicity update on the first 213 patients, which was presented last year. Next slide. Next slide. Just to highlight that Dr. Jawar, he did the presentation at ASTRO, who is one of the radiation oncology lead, and I'm doing the presentation today for Best of SWOG. We do have funding from NIH and also Genentech is supporting this trial. So these are some of the funding disclosures. Next slide. And these are my disclosure. I have some advisory role, paid roles with some pharmaceutical houses here listed here, and research funding from Genentech and EMD Serrano and writing fees. Next slide. So just to highlight this very important study, which is a concurrent chemoradiation bladder preservation option for our bladder cancer patients. This study actually highlights the culmination of efforts of patient advocacy, clinical research, and intergroup effort to design such a large study in US, which has historically failed to accrue very well on this type of design. If we look at past designs from previous studies, the largest randomized study accrued 120 patients in over 80 years. So this kind of effort had always struggled in the US, but I think this time was right. We were at a point where patient advocacy was pushing an agenda of bladder preservation to be explored for our patients in SWOG, and NCI took the effort to and believed that this is the right thing to do. So we put together this clinical trial, which was to explore addition of immunotherapy for concurrent chemoradiation, which is the standard of care for patients who either refuse radical cystectomy or not a good candidate for radical cystectomy for their bladder cancer. And these patients were then randomized on these two clinical treatment arms. These patients were stratified based on their clinical stage, whether they were early T2 versus T3, T4. We had an option for chemotherapy regimens. Either they could receive cisplatin or gemcitabine or 5-FU mitomycin. There were options for radiation field, whether a small pelvis or bladder only field, and also performance status. We allowed up to ECOG of 2 to be enrolled onto this study. The study, as you see, had a large sample size of 432 plus 10% for ineligible patients. So truly, we are looking for 475 patients on this trial. The primary objective of this trial is bladder intact event-free survival, and this is a registration trial led by SWOG in this field. It is interesting that how advocacy efforts with FDA can lead to they're open to an idea of not having an overall survival as an endpoint for a registration trial. We had long discussions with FDA that event-free survival in this particular population would be appropriate because that truly reflects the intent of the trial, and it includes not only muscle-invasive recurrence, it also includes systemic recurrence or patients having radical cystectomy for non-cancer reasons. So if a patient has toxicity and they end up getting radical cystectomy, that should be considered part of the composite endpoint. And so this is a novel endpoint being considered as a registration pathway for this molecule in this space. Other secondary objectives included overall survival and also pathological complete response rate for treatment, progression-free survival, complete response, metastases-free survival, cancer-specific survival, also looking at downstaging to non-muscle invasive recurrence rate, cystectomy rate, and also quality of life endpoints. We also included a very important translational piece in this study, which is being taken. Josh Meek is leading that effort for SWOG, and we are looking at MRE11 DNA damage repair mutations and immune markers to understand what are the patient population who would truly benefit with this as this trial will accrue and close. Next slide. So with that background, this is a statistical design. We were looking at a hazard ratio 1.46 for an improvement from 52 to 64% for BIEFS events at 3 years with a power of 85%. Our goal was to enroll 8 to 12 patients a month, which was a very aggressive goal when we designed the trial. We thought we'll accrue this trial in 4 years with completion at 7 with a 3-year follow-up built in. We actually have accrued close to 8 patients per month, and our accrual today stands at 362 patients, which is remarkable. This is the biggest trial for bladder preservation over the whole world. The next big trial was BC2001, which had close to 350 patients. So we have already enrolled more than that on this trial, and the trial is expected to finish accrual by end of this month. We did present the initial 80 patient data, which was built in as a safety benchmark because this trial did not precede with a phase 1 trial. So there was a safety run in, and those first 80 patients did not see any extra toxicity. And so the trial was allowed to move forward. And this abstract presented the toxicity update on the first 213 patients. Next slide. Excuse me. So just to give you a demographic breakdown on the patients, again, this is 213 patients. We now stand at 362 because this abstract submission was last year, January. In that group of patients, we had an average median age of 75 in the atezolizumab arm versus 72 in the CRT alone arm. We had more T2 patients, close to 82% patients were T2 and rest were T3, T4. If you look at the chemotherapy breakup among the patients, nearly half the patients got cisplatin as their chemotherapy of choice with radiation, and rest was split between gemcitabine and 5-fumaridomycin. Again, this was given an option because we wanted this design to be very pragmatic, so allowing physicians to choose their own chemotherapy regimen as part of their radiation, and that allowed for ease of accrual for the different sites. If you look at the radiation field, close to 57% patients had small pelvis, and other 43% had bladder-only radiation field. This is an important point to look at because the trial was designed with an anticipation to enroll 50% in T2 and 50% in T3, T4. And as you see, we are accruing more on the T2 side, but we have done internal audits. The chairs of the study have done internal audits of the patients enrolled, and we think that these patients who are being treated as small pelvis are truly more advanced than just T2, and they may compensate for lack of accrual on the T3, T4 side, because small pelvis, where the radiation oncologist or the urologist, they feel that the whole pelvis needs to be treated because their tumor is more advanced than what it appears to be clinically. And within our internal audits, we have kind of upgraded many of the patients to higher stage because we think that those patients are more advanced, just so that we feel that we will capture enough events in time, even though our T2 rate is higher. If you look at the performance status, we were hoping we'll have more ECOG-2 patients because this trial was designed to benefit patients coming across, and many of these patients who are not cystectomy candidates may have lower performance status, but on our trial, we are seeing most of the patients have 0 or 1 performance status. Next slide. From the safety point of view, this is the most important slide of the presentation. We see that if you look at the first column, the CRT arm, the 58% patients had any toxicity versus 44%. These are all grade 3 or higher. So clearly, the atezolizumab arm has more toxicity numerically. And one of the reasons could be that in this data set, we had 113 patients in the atezolizumab arm, whereas only 100 patients on the CRT alone arm. The next point is that most of the toxicities were hematological. They were cytopenias, either anemia, lymphopenia, neutropenia, or thrombocytopenia, and none of these events were considered immune-related by the treating investigators, and they continued with immune therapy on the patient when they were being treated. Only dose modifications were done on the chemotherapy side. We didn't observe any extra holding of immunotherapy, suggesting that this was all chemo radiation related rather than immune related. If you look at non-heme toxicity, we did see close to a third of the patients having non-heme toxicity. And we'll have a next slide which will describe more, but more to focus is on the colitis and cystitis, which were of very much concern to us when we were designing the trial. We felt that these patients getting radiation to the pelvis and we are giving immunotherapy, we are going to see an uptick of colitis or cystitis, which we didn't see on this trial. So which was very comforting in the sense that we are not adding any severe GI or GU toxicity to these patients by adding immunotherapy to the combination. We did have patients who had grade 3 diarrhea, but only 2 patients had grade 3 diarrhea and 2 patients had grade 3 cystitis in the atezo versus 1 in the control arm. Next slide. Other immune-related toxicities which were observed in the atezo arm was pancreatitis in one patient, rash, acute kidney injury, which were considered by the treating investigator as immune-related nephritis, one patient with gastritis, another one with transaminitis and dyspnea. These were all considered acceptable toxicities within the label of atezolizumab and were not considered to be excessive for the patient population being treated. Next slide. In summary, toxicities observed were higher in the atezolizumab arm. One reason could be the more eligible patients data available. Most of them were hematological toxicity and they were not considered related to immune therapy, so atezolizumab was not held on those patients. Known immune related adverse events were observed on the atezolizumab arm, which were considered acceptable, and no new safety signals were observed. And the trial is expected to finish now this year. End of this year, we should be able to complete accrual and present data in next coming years. Next slide. We would like to acknowledge our patients and caregivers, CRC and research staff at all sites, especially the NCOP sites. As Dr. Patel also referred, we had a massive chunk of our accrual comes from NCOP sites, and we take their input in consideration when we are designing our trials, and especially our patient advocate, Rick Banks, who played a big role in designing this trial. We really appreciate his efforts on this. And also the Stats Office, Kathy Tang and Melissa Pletz, and Taj and Laura were our remarkable team here at SWOG, which are helping us execute this trial, and appreciate Genentech team's effort and support for this trial. Next slide. Thank you.
Thank you. We have 10 seconds-ish. I'm being very brutal on time for a question. I think everything was crystal clear, and I want to thank you very much for presenting, Dr. Singh. We're going to move on now to Dr. Joe Unger, one of our statisticians. Dr. Unger is going to be presenting an incredibly interesting analysis of the impact and cost of 40 or so years of NCTN trials. Dr. Unger?
Thank you. Thank you, Dr. Blanke. And on behalf of my colleagues and co-authors from leadership across the adult network groups, I want to talk today about population, clinical, and scientific impact of the NCTN efforts over the decades. Next slide. So the NCI's National Cancer Clinical Trials Network, as we know, is a collection of oncology investigators conducting publicly funded cancer research in the US for more than 50 years, more than 60 years for SWOG. The network groups aim to identify effective new treatments for patients with cancer. They conduct research that parallels but broadens work done by pharma by comparing combinations of agents, testing regimens in rare diseases, and assessing different modalities such as surgery and radiation. And while they're widely thought to conduct high quality research, the actual benefit of the adult NCTN trials has never been systematically assessed. Next slide. So to conduct our analysis, we identified randomized phase 3 trials from the 4 adult network groups, SWOG, the Alliance, NRG, and ECOG Akron, reported from 1980 onward. To be included in the analysis, trial publications must have reported statistically significant findings for one or more clinical time-dependent outcomes, such as overall survival. Our aim was to estimate population clinical and scientific impact. Next slide. So population impact was defined by gains in population life years, calculated by deriving trial-specific hazard functions and hazard ratios to estimate the experimental treatment benefit, and then mapping this trial level benefit onto the US cancer population using National Cancer Registry and life table data. Life years were estimated from trials in which overall survival favored the experimental arm to any degree. Next slide. Clinical impact, meanwhile, was defined by influencing practice and was determined by whether trial findings were explicitly included as evidence in favor of a recommended treatment in a major clinical guideline or as in a new FDA drug approval. Scientific impact was defined by the number of times the trial was cited through Google Scholar, and impact estimates for all 3 domains were assessed through December 31st, 2020. Next slide. So here are the results. Out of an estimated 544 trials that were conducted over the period, 162 trials with 108,334 patients were analyzed. A wide variety of cancers were studied, most commonly tumors involving breast, GYN organs, lungs, and the prostate. Next slide. Overall, 133 trials showed overall survival favoring the experimental arm. These trials were estimated to have generated 14.2 million additional life years at a federal investment cost of about $328 per life year through 2020. And so just to contextualize these findings, a gain of 14.2 million life years through 2020 due to the contributions of these NCTN trials has returned or is estimated to have returned about 4.2% of the more than 300 million life years lost due to cancer from 1980 through 2020 in the US. Next slide. For these same trials, the projected estimates for 2025 and 2030 are 19 million and 24.1 million life years gained respectively. And keep in mind, this estimate is conservative since it relies only on the studies we examined and does not attempt to model how many studies will be positive in the future. Next slide. We also examine the robustness of our estimates by allowing key parameters to vary in this colorful slide, including the duration of the assumed treatment effect, which we allowed to vary from 3 to 7 years compared to its base case of 5 years. The year of new treatment adoption was allowed to vary from 2 years prior to 2 years after publication compared to a base case of the year of publication. And the effectiveness or generalizability parameter was allowed to range from 80% to 120% compared to a base case of 100%. The overall range of estimates was 7.8 to 22 million life years, and 91.2% of the estimates exceeded 10 million life years. Next slide. A large majority, nearly 90% of trials were found to have influenced cancer care guidelines. Since the NCCN guidelines, our primary source, became available in 1996, the estimate is actually higher at 96%, indicating that we may have missed some in earlier years. Next slide. Primary trial results were cited more than 165,000 times with a mean of 62 citations per year per trial. 58% had more than 500 citations through 2020, and 90% were published in high-impact journals, including JCO and New England Journal of Medicine, the two top journals. Next slide. So in conclusion, randomized trials conducted by the NCI NCTN groups have generated substantial gains in life years for patients with cancer. These studies have been extremely influential, frequently influencing formal treatment guidelines and frequently being cited in the literature. And as concluded by Dr. Friedberg, editor-in-chief of JCO, who provided the statement on relevance in the paper, the impact of US NCTN trials on adult cancer outcomes cannot be overstated. This evidence should compel sustained financial investment and continued academic contributions to this valuable resource. Last slide, please. And in my acknowledgements slide, I just want to actually quote Dr. Bertignoli, who's the current director of the NCI, who said, "First and foremost, we commend the generosity and courage of patients who participate in clinical trials. This work is a clear demonstration that those who do so make a tremendous contribution to society. We also acknowledge the work of clinical providers and other caregivers who go above and beyond usual care to make clinical trials possible. This result validates the key role of NCTN and other networks in improving the outlook for patients with cancer and progressing toward our goal to reduce the cancer death rate by half within 25 years. Thank you.
Joe, thanks so much. I truly cannot overstate the importance of the work and how helpful this is going to be to all the adult groups in their next grant application. I also appreciate your staying on time, and we have some questions. The first one appears to be, can you comment on trials in which overall survival in the experimental arm was equivalent or inferior to standard therapy?
This analysis was based only on those trials where overall survival was superior, because we were looking to estimate life years gained. We do recognize that there are benefits from those other trials as well, and where those trials were designed to be non-inferiority trials, for instance, and were positive, they were tallied as a positive trial and included in the calculations of clinical impact as well as scientific impact. But we did discuss those in our discussion as well, and the value of those contributions, which are critical as well. Thank you.
I suppose an extension, though, might be if you factor in the negative trials, that the cost of doing research is higher than $328 or so per life year saved. Would you agree with that? Or are you doing that assessment?
So the estimate of the cost estimate takes into account all the trials that were conducted. So it's the funding for the entire pot, not just the positive trials.
Oh, that's fantastic to hear.
Yeah.
And then I have a question myself. The incredibly rare naysayer of this work has said, well, SWOG Stats is really smart, and they just use some statistical tricks to come up with these numbers. But the fact that 96% of these influenced NCCN trials, to me, really argues that these results are real and that they are highly impactful clinically. Would you agree with that?
Yes. And I mean, of course, I'm not sure how to respond to some of that, but certainly we laid out all of our assumptions. People are certainly, it's their right to interrogate them. We tried to be conservative in our assumptions where possible, because we recognize that we want the estimates to have some face validity. Even then, you know, there will be doubters, but they are welcome to do their own analysis as well.
Good. And I definitely encourage everybody on this webinar to look at the manuscript. It's so exciting. So next, it gives me incredible pleasure to introduce Dr. Mariana Chavez Mac Gregor, who is our executive officer in charge of international affairs. She will be discussing S1207, which was presented at the San Antonio conference last year.
Thank you so much, Dr. Blanke, for selecting our work for presentation at Best.SWOG. What I'm going to do in the next 8 minutes or so is discuss with you the results of SWOG 1207. This is a phase 3 randomized placebo-controlled clinical trial that evaluated the use of 1 year of everolimus in combination with adjuvant endocrine therapy in patients with high-risk hormone receptor-positive, HER2-negative breast cancer. Next slide. These are my potential conflicts of interest. Next slide. We know that in patients that have hormone receptor-positive tumors, dysregulations or abnormalities in the PI3 kinase pathway can be associated with endocrine therapy resistance. Everolimus is an mTOR inhibitor that in the metastatic setting demonstrated that it could, in combination with endocrine therapy, prolong the progression-free survival in patients that have been previously treated with aromatase inhibitors. So with this in mind, it became a very important question to evaluate whether everolimus used in the early stage setting could improve the outcomes of patients with high-risk tumors. And with that in mind, we designed 1207. Next slide. In this trial, we recruited patients that were older than 18 years of age that had histologically confirmed invasive hormone receptor-positive, HER2-negative, high-risk breast cancer. It is very important to mention that all the patients in this trial were required to have completed either adjuvant or neoadjuvant chemotherapy. And we define high risk as belonging to one of these 4 groups listed in the slide. This is very represented in the figure that I have next, please. Next. So patients could have been accrued to the trial through different eligibility criteria that are associated with these high-risk groups that we define. So if patients underwent surgery first, they were eligible if they had no negative tumors, but those tumors were greater than 2 centimeters and tumors were high recurrence score or MammaPrint high risk. If patients had 1, 2, 3 positive nodes, they were only eligible if the recurrence score was greater than 25, their MammaPrint was high risk, or they had grade 3 tumors. And all patients with 4 more positive lymph nodes were eligible. All these patients that received surgery as initial treatment strategy had to have complete adjuvant chemotherapy and radiation therapy as standard of care before randomization. Now, for those patients in the right side of the slide in lighter gray that were treated with neoadjuvant systemic chemotherapy, only those that had at least 1 positive lymph node as residual disease were eligible for the trial. And also they needed to have completed radiation therapy if that was indicated. So based on these 4 categories, patients were stratified and randomized to receive adjuvant endocrine therapy, selection of physician's choice, and either everolimus or placebo. The everolimus was given at a dose of 10 milligrams daily for a duration of 1 year. Next slide. The primary endpoint of the study was invasive disease-free survival. We calculated a sample size of 1,900 patients, and it was defined that we will conduct 3 interim analysis upon observations of 40, 60, and 80% of the events. And at each interim analysis, futility was also tested. Important secondary endpoints were overall survival, safety, and we specify subset analysis in certain groups according to high risk, and also not plan analysis according to different patient characteristics. Next slide. These are some of the statistical considerations, and as you can see, after activation of the trial, the design changed. Initially, we had estimated that we were going to recruit 3,500 patients. That was revised, and it was finalized at 1,900 patients. This was a result of 2 factors. One, slow accrual, and the second one, it was just to better reflect the population that we were recruiting. We started to recruit more patients that belong to higher risk patients, mainly those with residual disease after neoadjuvant chemotherapy and more than 4 positive lymph nodes. So this design was established and applied in April 2016, and no outcome information was used to change the design, and it should be importantly noted. Next. So in the final analysis, we planned when 219 invasive disease-free survival events occur in the control arm or 3 years after last randomization. This final analysis occur after 3 years of last randomization, and when actually 211 invasive disease-free survivals had occurred in the control arm. Next. In total, 1,939 patients were randomized, as you can see, to the everolimus arm or the placebo arm. And after ineligible patients were excluded, we had equal number, 896 patients, including the analysis for each arm. Main reasons for ineligibility actually were tumors that were HER2 positive or HER2 unknown. As of the last October 11, median follow-up among alive patients was 55.2 months. Next. Next. In this table, I show the patient characteristics. As you can see, in general, it's a relatively young patient population. The majority of the patients were white, although 6% of them self-identify as Blacks and 9% as Hispanics. And in the blue square, you can see the distribution according to the different risk groups that I mentioned as part of the eligibility criteria. The majority of the patients, 80% of the patients in the trial, either had 4 more positive lymph nodes or had greater than 1 positive lymph node that was residual after neoadjuvant chemotherapy, and 32% of our patients were defined as premenopausal. Next slide. This slide reflects the treatment summary, and if you can click the next 3 slides. What you can see in the blue boxes are the completion of treatment and the adverse events. So it's very important to know that 73% of the patients in the placebo arm completed 1 year of treatment, compared with only 48% in the patients treated with everolimus, meaning more than half of the patients in the active study armed with everolimus did not complete the planned 1 year of therapy. This was mostly driven for adverse events. As you can see, the main reason of discontinuation, 30% of the patients was adverse event in the everolimus arm, contrasting with only 10% on the placebo arm. In the last blue box, you see the proportion of patients that discontinued treatment due to relapse. That was 2% in everolimus arm and 5% in the placebo arm. Next. This is the primary endpoint of the study. It's a negative study. For the primary endpoint, we did not observe that the treatment with 1 year of everolimus in addition of endocrine therapy improved invasive disease-free survival, with curves that, as you can see, are one, superimposed to the other. Next. In the subgroup analysis, we did not see any major differences according to age or risk group. However, we did see a signal suggesting improved outcomes in patients that were premenopausal. Next. This is secondary endpoint of overall survival, also demonstrating that everolimus in the entire patient population, it's not associated with improved overall survival in this group of patients. Next. Now, given the suggestion also in the exploratory analysis among subgroups of overall survival and the ones that I show you for invasive disease-free survival, we conducted an exploratory analysis according to menopausal status. In the Kaplan-Meier curve that you see, it's the invasive disease-free survival for post-menopausal patients, consistent with the overall cohort, no improvement in outcomes associated with the use of everolimus. However, next slide. Amongst premenopausal patients, we observed in blue that the use of everolimus was associated with statistically significant improvement in invasive disease-free survival, with curves that separate early on at around 1 year. When we evaluated in a Cox regression model the interaction between treatment arm and menopausal status, this was statistically significant. Next. Consistent with this analysis, we also conducted an exploratory analysis for overall survival, and the results are strikingly similar. For the postmenopausal patients that you see currently on the slide, there are no differences, and this is in consistency with the main analysis for the trial. However, next slide. Among the premenopausal patients, we see exactly the same phenomenon that we observe for invasive disease-free survival, where premenopausal patients treated with adjuvant everolimus in combination with endocrine therapy had improved outcomes, in this case with a hazard ratio of 0.49. And we also observed a statistically significant hazard ratio when testing the interaction between treatment arm and menopausal status. Next slide. A very important secondary endpoint was toxicity. And as you can see, there were more toxicities in the patients treated with everolimus. In the table, you can see the proportion of patients with grade 3 or greater toxicities. There were 35% of patients experiencing grade 3 and 4. There were actually no grade 5 toxicities, compared with 7% in patients treated with placebo. The most frequent grade 3 and 4 toxicities are consistent with what we knew about the drug, and they are mucositis, lymphopenia, hypertriglyceridemia, and hyperglycemia. And the proportion of the grade 1 and 2 events also represents what we already knew about the drug. Next. So in conclusion, in 1207, the addition of 1 year of adjuvant everolimus to standard adjuvant endocrine therapy in high-risk early-stage breast cancer patients with hormone receptor-positive, HER2-negative tumors did not improve invasive disease-free survival or overall survival. We observed a low completion rate in the patients treated with everolimus and increased adverse events in this group of patients. However, there were no new safety signals compared to what we already knew about the use of everolimus as it came to side effects. Among premenopausal patients, the addition of everolimus to endocrine therapy improved invasive disease-free survival and overall survival. We found that this is a very interesting observation. However, it's only hypothesis generating, since it was not a pre-planned analysis. And of course, we're very excited to announce that very interesting translational studies under the leadership of Dr. Elijah Spustai are going to evaluate potential predictors of everolimus benefit, drug toxicity, that may have implication for other drugs that are targeting this current pathway. Next. Just to finalize, of course, this was a tremendous effort amongst all the investigators and staff across the country, and very importantly, all the patients, families, and caregivers that volunteered to participate in the study and our funding agencies. Thank you.
Mariana, thanks so much. I don't see anything in chat yet, so let me ask you the question I'm sure you've been asked a bazillion times. Do you think any clinicians are using the data in premenopausal women right now?
No.
Oh, that was easier than I thought. Then let me ask you a slightly harder one, which is, no matter how great a treatment is, it doesn't matter if you can't get it in. If these data do pan out in further studies in that population, or even a bigger population, do you have ways to mitigate the side effects?
So I think something that we have learned about the use of everolimus was that early prevention and early interventions decrease the frequency of side effects, specifically mucositis. By the time we activated the study, actually it took an amendment to recommend the use of steroid mouthwash for the participants, because we learned from the Swiss trial that was important. However, we couldn't mandate it, and even if we highly recommended it and established webinars to discuss toxicity management, we don't think that it really became standard practice. So definitely toxicity was an issue. I think it brings the important point on how to make this longer treatments tolerable for patients, right? These patients had finished chemotherapy, et cetera, something that the French group did because of high toxicity and slow accrual was to actually modify the trial and start at a lower dose. They started 5 milligrams and then increase. So I think it forces us to think in the adjuvant setting, different patient populations, right? Patients that the goal is cure, to maybe think about better toxicity management strategies and maybe even lower doses as we start.
Fabulous, fabulous answer and fabulous trial. Thank you so much. So our final presentation today is from Dr. Yara Abdou, who'll be talking about race and ethnicity association with the outcomes in S1007. I want to just quickly point out how it really nicely highlights the work SWOG does, not just in identifying new treatments, but in looking at broader population science related issues for benefit. So Dr. Abdou, please take it away. I hope. Whitney or Casey, I know Dr. Abdou was worried about getting on late. Do we know if they are signed on?
Sorry, I was unmuted and I couldn't unmute myself.
It's okay, much better.
Sorry,
That's an easier
muted
explanation. Welcome.
Thank you. All right, hello everyone. Thank you for inviting me to speak today at Best of SWOG. I'll be presenting the race and clinical outcomes results from the RxPONDER trial. Next slide, please. These are my disclosures. Next slide. Racial disparities in breast cancer outcomes continue to be a major healthcare challenge. U.S. Black women have 4% lower incidence of breast cancer, yet 40% higher breast cancer mortality than white women. Other studies have found that disparities persist even after adjustments for non-biological factors. Here we report an analysis of clinical pathological characteristics, survival outcomes, and race in association with the recurrence score in participants in the RxPONDER trial. Next, please. Objectives of the study included evaluating the entire cohort by race for clinical and pathological characteristics and recurrence score distribution, analyzing clinical outcomes by race using two endpoints, invasive disease-free survival and distant relapse-free survival, determining whether race was independently prognostic and determining whether race is predictive of treatment benefit. Next, please. The study included a total of 4,048 women with known race and ethnicity. About 70% were non-Hispanic white, about 6% were non-Hispanic blacks, 15% were Hispanic, 8% were Asians, and about 1% were Native American Pacific Islander. Next, please. These are the clinical pathologic characteristics by race and ethnicity. We note that non-Hispanic blacks did not differ in age compared to non-Hispanic white women, whereas non-Hispanic Asian women were notably younger than other racial cohorts. Next, please. There were no significant differences in number of positive lymph nodes involved or tumor size across all racial groups. Next, please. There were also no significant differences in recurrence score distribution by race and ethnicity. Next, please. However, histologic grade was significantly different, where non-Hispanic Black participants had fewer low-grade tumors and more high-grade tumors compared to non-Hispanic whites. Next, please. Non-Hispanic Blacks also had higher BMI compared to other cohorts, whereas non-Hispanic Asians were noted to have lower BMI scores. Next. Looking at treatments type by race, we note that among the premenopausal women, the non-Hispanic Black woman received less anthracycline chemotherapy than the non-Hispanic white woman. In the postmenopausal group, there were no differences in the chemotherapy received. Endocrine therapy selection was similar for non-Hispanic whites and Blacks. Next, please. When looking at invasive disease-free survival by race and ethnicity overall, the non-Hispanic Black cohort had a 5-year IDFS of 87.2% compared to 91.5% in the non-Hispanic white cohort, with an unadjusted hazard ratio of 1.39 and a p-value of 0.04. Next, please. In a separate analysis stratified by menopausal status, we note a similar magnitude of worse IDFS for non-Hispanic Blacks in both the pre- and postmenopausal groups, although no longer statistically significant. Next, please. A multivariable Cox model adjusting for recurrence score, treatment arm, menopausal status, age, and grade did not alter the impact of race. We continue to note worse IDFS for non-Hispanic Blacks compared to non-Hispanic whites with a hazard ratio of 1.37, while Asian patients had a superior IDFS compared to non-Hispanic whites with a hazard ratio of 0.67. Next, please. When BMI was added to this model, the magnitude of the race effect decreases, although we continue to note worse IDFS for non-Hispanic Blacks compared to non-Hispanic whites and a superior IDFS for Asians compared to non-Hispanic whites. Next, please. In terms of treatment effect, there were no significant interaction between race and treatment arm in either postmenopausal or premenopausal cohorts. However, it's important to note that there were a limited number of events in the non-Hispanic Black cohort. Therefore, any apparent treatment differences by race should be considered hypothesis generating. Next, please. When looking at distant relapse-free survival by white and Black race, the non-Hispanic Black cohort had a 5-year DRFS of 90.1% compared to 94.7% in the non-Hispanic white cohort, with an unadjusted hazard ratio of 1.39 and a p-value of 0.004. Next, please. The multivariable Cox model that continued to show worse DRFS for non-Hispanic Blacks compared to non-Hispanic whites with a hazard ratio of 1.71. Next, please. Once again, when BMI was added to this model, the magnitude of the race effect decreases, but we continue to note worse DRFS for non-Hispanic Blacks compared to non-Hispanic whites with a hazard ratio of 1.31. Next, please. When looking at treatment assignments at the time of randomization, 93% of non-Hispanic Blacks accepted their treatment assignment compared to 86% of non-Hispanic whites. Next, please. Additionally, when looking at endocrine therapy adherence within the first year, non-Hispanic Blacks were slightly more likely to adhere to their endocrine therapy at the 6-month and 12-month intervals compared to non-Hispanic whites. Adherence data beyond that first year is still immature. Next, please. In conclusion, non-Hispanic Black women with hormone-positive, HER2-negative breast cancer, 1 to 3 involved lymph nodes, and recurrence score of less than or equal to 25 have worse outcomes compared to non-Hispanic white women, independent of recurrence score, treatment arm, age, and grade, although adjusting for BMI appears to decrease this effect. At this time, definitive conclusions about racial differences in treatment benefit cannot be made due to the limited number of events in the non-Hispanic Black cohort. Next, please. Non-Hispanic Blacks were more likely to accept their treatment assignment compared to non-Hispanic whites and were just as likely to remain on endocrine therapy at that 6 and 12-month intervals. These data suggest that the outcome differences are less likely attributable to lack of treatment compliance within that first year. Longer follow-up and further analysis is needed to confirm this finding. Next, please. For future directions, tumor biology, such as proliferation gene groups, may differ by race, contributing to noted disparities. Therefore, future analysis of gene groups by race and responder will be explored. Outcome differences may remain due to healthcare access issues, since treatment within a clinical trial can still differ across patients. Therefore, future analysis of social determinants of health based on geographic location will also be explored. We also plan to assess the likelihood of treatment completion and adherence by race and ethnicity beyond that first year. Next, please. We would like to thank the patients and their support system for their participation, and of course, the study sponsors for the support of the study. Thank you, everyone.
Great, thanks very much. We do have time for a question or two. Let me go ahead and ask you one. Obviously, differences in pharmacogenomics or tumor biology are incredibly fascinating. I'm glad you're exploring them. But you also made the really interesting statement that treatment within a trial can vary based on access. And so it implies that not only are some of the patients having trouble, it means they're not having trouble finding the trial, but once they're on it, they're having trouble. Do you mean they're having trouble getting to appointments, or are there other social determinants that you were thinking about?
So part of the follow-up might be different. So patients might not be getting to appointments, might not be compliant to appointments because of social determinants of health. But the other thing that was interesting that we found in our study is that premenopausal non-Hispanic Black patients got less anthracycline chemotherapy than premenopausal white women. So it was up to the provider discretion to provide chemotherapy to these patients, wasn't indicated as part of the trial, and we saw differences in treatment. So I'm not sure the reason behind this is and whether that contributed to disparities, but we did note that as part of our analysis. So I think exploring the reasons behind this would be beneficial.
Well, that was just fantastic. Thank you. I'll close. I always think that SWOG is a great group, and we are doing great research thanks to many of the people on this call, many of our members. I want to throw a shout out to Casey Dawson, Whitney Leslie, and Frank DeSano for setting us up. I really, really want to thank our presenters, and of course, I want to thank all of our attendees. We're hoping to do this a couple more times this year, so please stay tuned. Have a great rest of the week. Bye-bye.